So Brecht, you can start the recording. So welcome everyone, dear participants, dear colleagues. We have a new webinar for you today from our Burden EU cost action. Today we will have two very nice presentations on a very important topic. It will be about environmental noise and its impact on population health. So we know from the evidence from the last couple of years that noise is really related and associated with a very high variety of different health outcomes, from annoyance to cardiovascular diseases. So we know that it is very important for population health. And this is why we have brought this topic to you today. And we have two wonderful speakers that will present two topics related to environmental noise and the according burden of disease. We have the two speakers, Eulalia Paris from the European Environment Agency, and Gunmarit Aswang from the Institute for Public Health in Norway. So without further ado, I would say that we will have Eulalia first to start. We will have a discussion at the end of both talks. So we will first have the two presentations and then we will have the overall discussion. So welcome to everyone and welcome especially to Eulalia, who is an environmental noise expert from the European Environmental Agency. She manages the noise data in the European Environmental Information Observation Network, so the IONET network. And she holds a PhD in acoustics from the University of Salford in UK. And she is a senior expert on noise in the European Environment Agency. So Eulalia, the floor is yours. Thank you very much again for your presentation and your willingness to present here in our webinar. So
thank you. Thanks very much. Thanks very much for the introduction, and thanks for inviting me to this webinar. And sorry for the very long title. The long title is because I will speak about two slightly different topics. First of all, I will give an overview on the joint WHO-EA briefing on the uptake and impact of the WHO environmental noise guidelines for the European region. These were some guidelines that were published in 2018, and they comprise a set of meta-analyses on different health outcomes and noise exposure. And they came up, one of the main things was that these guidelines presented some recommendations for noise levels. So this brief was published last June, and it is a joint collaboration between the WHO and the EA to evaluate the uptake by relevant stakeholders of these 2018 WHO environmental noise guidelines. And we did that by collecting a survey among WHO and EA member countries. And secondly, I will speak briefly about the noise health impact assessments that we undertake at European level based on the data we gather under the Environmental Noise Directive. We do this once every 5 years approximately, and specifically I would like to give an overview on some insights into the upcoming EU-wide noise health risk assessment for 2025. So I will start by speaking about this work on the uptake and impact of the 2018 WHO noise guidelines for the European region. The idea of this work was to investigate the degree of implementation of the WHO environmental noise guidelines by relevant stakeholders. And we were interested not only on the impact on local, regional, or national policies per se, but we were interested also to capture other more minor impacts that could have emerged from the publication of the guidelines, like, for example, maybe the start of some debates in some institutions, maybe the organization of some workshops, maybe an increased interest in some of the countries, etc. I also want to mention that this work was commissioned by the WHO, but also involved UBA Germany and Swiss TPH. So what we did was to distribute a questionnaire amongst relevant stakeholders in 2022. The WHO sent the questionnaires to their network of countries, and the EA, we sent the questionnaire to our network of countries that work on noise. We gathered 100 responses, but many of these questionnaires were incomplete. In total, we had about 1/3 of these 100 responses that completed the questionnaire. And the reason of this kind of incompleteness response, we think that was because it is very difficult for one person to have a complete overview of the actions that are taken as regards to noise in a country. The questionnaire would have also different questions depending on the respondent. So for instance, there was a split between questions. Some questions were targeting relevant stakeholders from regional and local institutions, and some other questions were targeting stakeholders from national institutions. And the types of questions that were asked were more or less about, okay, the impact of the WHO environmental noise guidelines, which was the single most relevant impact. Also, what they thought they were the most helpful aspects of the guidelines. What they thought there were the main barriers for the implementation of the recommendations of the guidelines. And also if they had some thoughts for further improvement of the guidelines, and also what they would think would be kind of relevant tools or information or products that would support the guidelines, or that it could be done to supplement the guidelines. So here there are the main results of the uptake and impact of the guidelines. First of all, it seems that the guidelines triggered some policy actions, mainly at supranational level, like, for example, the revision of the Annex 3 of the directive, but also, and probably linked to the Annex 3, the guidelines also triggered actions at national and regional and local level. Just for the ones that don't know what is this Annex 3 of the directive, this is a text of the directives that obliges country to quantify health effects using the exposure response relationships from the guidelines, and also sets some health outcomes that have to be quantified. So countries need to use this approach. Also, the guidelines have also triggered the adoption of new or additional noise sources in law regulations. The guidelines also trigger some actions as regards to strategic noise maps and action plans, like would be, for example, the mapping at lower bands than those specified in the Environmental Noise Directive. So for instance, the Environmental Noise Directive obliges countries to map noise from road, rail, and aircraft from 55 dB LDN and 50 dB L-night. So these guidelines trigger some actions in some of the countries to start mapping noise below these END thresholds. The guidelines were also helpful to unify the approach in estimating health impacts of noise. So as mentioned, in the Annex 3, there are some specific ways and specific health outcomes that need to be used for estimating the health impacts of noise. So countries need to adhere to those. And Finally, some countries have developed noise limits based on some of the principles of the guidelines. This doesn't mean that the countries have used the recommended levels, but use some of the bases of the guidelines to develop some new noise limits. The main strengths that were mentioned by the countries were that the methodology was transparent and that there was a well-defined rating of evidence quality in the guidelines, that the guideline values were source specific, so different recommendations were set for different sources, road, railway, aircraft, and also wind turbines. And that the publication of the guidelines have actually increased the appetite for more research in the field and for more high quality studies. Some challenges and barriers of the guidelines were also identified. So, for instance, the main concerns were that it seemed for countries not feasible at the moment to reach the levels proposed by the WHO. And there are concerns about the economic costs associated with the implementation of the noise recommendations proposed in the guidelines. And also respondents identified as a challenge the lack of interim targets to bridge the gap from current levels to the ones recommended in the guidelines. As regards to improving the health risk assessment, countries mentioned that quantifying the health effects of environmental noise is complex due to the wide range of acoustic parameters involved. They said also that additional noise metrics could be useful apart from LDN and LNIght, as some health impacts can also be triggered by the level of individual events or the number of events. At the moment, for the ones who don't know, the guidelines propose or the recommendations are made using these two indicators, LDN, which is a kind of an average for the day, evening, and night period, and LNIght, which is the level during the night period. They also mentioned that the protection of vulnerable groups should be considered. This is something that the guidelines didn't touch upon. But countries said that this would be helpful. Countries also would appreciate recommendations of overall exposure levels and also levels combined with other environmental pollutants. And that also special attention should be given to emerging health outcomes. At the time of the publication of the guidelines, only a number of health outcomes were considered, but yeah, countries said that could be helpful also to include other health outcomes. The survey also asked about the quantification of health impacts and what they thought about the tools that the guidelines provide for conducting health impact assessments. And the main comments were that they appreciated the tools provided because health impact assessment of environmental noise is essential for informed decision making. They also said that guidance on exposure response functions is valuable. They also said that tools to support the quantification of health impacts are useful, and a quarter of the survey respondents reported that they already use this health impact assessment to assess the health impacts of policy measures or projects. And the brief also mentions future needs that were identified. For instance, they said that it would be helpful to have tools or more tools that support the quantification of health impacts. They also said that more research on emerging adverse health impacts would be useful, because at the time of writing of the guidelines, there was still not a lot of good quality evidence on certain health outcomes. They also mentioned that maybe it would be good to have improved methodologies. And also they mentioned that it could be useful to have a roadmap to reach the guideline levels of the WHO that consider also the costs and benefits. So that is the overview for the policy brief with the WHO. And now I'm going to move into the insights for the new EA health risk assessment. So at the European Environment Agency, we publish a report on noise more or less every 5 years, and that includes a EU-wide health risk assessment on noise. And this is done with data submitted by the EA countries under the Environmental Noise Directive. And we also publish other products like indicators, briefings, etc., linked to this report and that contain information on health impacts of noise. But this report is kind of the basis of everything. And the last report we published was in 2020. And we are working towards a new report for 2025, and we have started some of the work. Specifically, last year we worked on developing a new methodology for this upcoming EU-wide health risk assessment. And this was done by our partners from the European Topic Center on Human Health and the Environment, and which for this work was Swiss TPH. And the work includes a systematic review and a meta-analysis, amongst other things. And this was done because there is a new body of evidence since the publication of the last report and the previous methodology. And this report that I just mentioned, it's not published yet, but it will be published soon, this report of the meta-analysis and the methodology. And for our previous report, we mainly consider the information from the WHO guidelines. And you can see the health outcomes in red that the WHO recommended to be included in a health risk assessment, and also the ones for which there was a weaker evidence and that the WHO stated that can be potentially included in a noise health risk assessment. Unfortunately, the WHO guidelines only capture studies up to 2016, but by today there is an increased quality of evidence for some cardiometabolic risk factors, and there are also other emerging health impacts, especially for road traffic noise. So in 2020, we only considered the outcomes that were in dark red from the previous slide, which were high annoyance, high sleep disturbance, incidence of ischemic heart disease for all sources, reading impairment for children in the case of aircraft noise, and we also added premature mortality due to ischemic heart disease for all sources. Another thing to mention is that the health risk assessment was done using the END threshold, so data on population exposed to noise levels above 55 dB LDN, exposed to noise levels below 50 dB LDN or 50 dB L-night were not considered in the previous assessment. And we also quantify noise impacts in terms of years of life loss, years lived with disability, and DALYs using the WHO disability weights. And this is a bit what we are planning to change from the previous EU-wide noise health risk assessment. Based on a systematic review and a meta-analysis done by our partners, as explained, The new EU-wide noise health risk assessment will consider the following additional health outcomes. Will include diabetes, will include a wider range of cardiovascular diseases, including not only ischemic heart disease, but also heart failure, hypertension, and stroke. And we will also group everything as cardiovascular outcomes rather than shown individually. And we will also use all natural cause mortality instead of mortality due to ischemic heart disease. We will provide also estimations of people suffering these effects, not only for the people exposed above the END thresholds, but also considering the WHO recommended levels and below. And in addition to this, lower thresholds of effect, starting at 45 dB LDN and 40 dB L-night, will be considered. And we also plan to use updated disability weights. We are kind of waiting for the results of a study that looked at noise disability weights. I think the WHO is also involved in this. And finally, we will also have some additional information on the impacts of noise on other health outcomes that are emerging outcomes, like, for example, depression or something similar. We have not decided yet, but we'll try to do something like this as a kind of additional information. So as a result of most of these changes, especially this, including these new health outcomes, these estimations below the END thresholds, and using also these lower thresholds of effect, it is anticipated that the disease burden related to noise from transport will be higher than previously estimated in previous years. So that's all from my side. Here I leave some other information in case you are interested. And thank you very much for listening.
Yes, thank you very much, Eulalia, and thank you also for presenting the plans of 2025 to have this improved and new environmental burden of disease assessment for noise. I'm very much looking forward to this one. So, as I said, keep your questions. We will have a discussion for both of the talks afterwards. So I will now invite Gunn-Marit Aswang for the next talk. Gunn-Marit is a senior scientist in environmental epidemiology in the Norwegian Institute for Public Health. She is an expert in the field of noise already since more than 25 years. She will now have will zoom into the Nordic countries and will present about the burden of disease due to transportation noise in the Nordic countries, and will show some experiences that she and her colleagues had when using the data from the strategic noise mapping. So Gunn-Marit, you can share your screen. I see it already works now. Just have to start your presentation, and then I will give the floor to you. I hope it works well.
Sorry, I need to so can you see my presentation now?
We can see your screen, but not the presentation. But I think it's changing. No?
No?
Not yet?
Not yet. That's strange. And now? Can you see it now?
Unfortunately not. No?
No, it's... I need to stop sharing and try again, perhaps?
Yes. Yes, yes.
I'm most used to Teams, so
yes.
This is a little bit more challenging. Sorry for that. But it's okay. Sorry, I tested it.
Yeah, it worked.
Before,
as we tested.
Sorry for this.
No worries.
No, wait. Share. Perhaps I shall share application instead of screen, or?
Yes, you can, and then you can choose the PowerPoint.
Yeah.
That should work.
Window. perhaps this will. Okay, I'll test this one.
Oh, something is working. Yeah, okay. It's
Yeah,
still in presenter mode, so if you make it to full screen, it should work.
Yeah, it's it doesn't seem so nice on my screen, but yeah. Okay, is it?
We can see it now. Yes.
Is it in full screen mode or?
It's in full screen. Yes.
Okay, fine. Thank you. So
Perfect. Thank you very much.
Yeah, hello everyone, and thank you for inviting me to this webinar. I will talk about a project that where we assessed burn-off disease due to transportation noise in the Nordic countries. And I will talk about our experiences with the use of the data from the strategic noise mapping, which Alalia now talked about, the data that are reported to the European Commission. So can you see my next slide?
Yes, perfect.
Yeah, okay. So the aims of this project were to estimate the burn-off disease due to road traffic noise and railway noise in the Nordic countries and their capital cities. And that is Norway, Sweden, Finland, and Denmark, and their capital cities Oslo, Stockholm, Helsinki, as well as Copenhagen. And we also wanted to establish a common framework for this BOD assessment across the Nordic countries to arrive at comparable estimates. And this project was a Nordic collaboration called Norwegian project, which was funded by the Nordforsk. So to have a little bit outline of the methods, we assessed the burn-off disease in terms of disability adjusted life years, as most of you probably know a lot about. This study measure include both fatal and non-fatal health loss and adds the years lived with disability, illness, or injury with the years of life lost due to premature death. And in this project, we used the so-called exposure-based method, where we obtained noise exposure distributions, in this case from road traffic and railway noise for the populations. And we used exposure response functions from research. And we also need to obtain the disability rates for the non-fatal outcomes, in addition to background health data on both morbidity as well as mortality. So to go a little bit more into detail for the noise exposure, in the research group used quite a lot of time to try to collect all kinds of noise exposure mappings in these countries. And we ended up with using noise mappings from the Environmental Noise Directive. That is the data that needs to be reported to the European Commission every 5th year. And this noise mapping, as we call strategic noise mapping, does not cover the entire countries. But the criteria for this mapping is for all agglomerations with more than 100,000 inhabitants, in addition to outside these urban areas along major roads and rails. And as has been said by Alalia, the threshold is that all areas needs to be mapped, which is above 55 LDN and above 50 dB for the nighttime noise level, the L-night indicator. And these data are accessible from the European Environmental Agency, so that they are really available. And of course, also available for all the Nordic countries. And in this project, we use data from the 2016 mapping. In Norway and Denmark, we also have available nationwide noise mapping. So we also use these data. And these data covers all residential buildings in the country, in contrast to the end mappings. So, and regarding the outcomes, we included a set of main health outcomes, more or less what was recommended in the WHO environmental noise guidelines. That is the annoyance, high sleep disturbances, as well as ischemic heart disease. And we also used the risk estimates and the risk functions from the WHO review. Annoyance and sleep disturbances were only included for railway noise and ischemic heart disease in addition for road traffic noise. As has been said also, there is more and more evidence also for other cardiovascular outcomes such as stroke and also diabetes. So in additional analysis, we included also stroke and diabetes for road traffic noise in our assessment. And we used the risk estimate from a large Nordic study from Rosvall from 2021. And regarding diabetes, we did a new meta-analysis based on the results from meta-analysis in 2019 by Viano et al. And we choose to use YLD and YLL rates for these outcomes, IHD, stroke, and diabetes from the Global Burden of Disease study. And we thought that was an advantage because these background rates are harmonized across the countries, and they already includes the disability weights for the YLD estimates. So it's a big difference between these kinds of health outcomes when we estimate the DALYs, because high annoyance and high sleep disturbance, they are directly assessed based on the noise exposure distribution and the exposure risk functions. And we don't need any background data for this, because if you have the noise exposure distribution and the exposure risk function, as well as the disability weight, you can calculate the YLD directly. And in this case, we also use the disability weights recommended by the WHO for both annoyance and high degree of sleep disturbances. And in contrast, when estimating the YLD and YLL from IHD, stroke, and diabetes, we do this in the traditional way by estimation the population attributable fraction for each health outcome. And this is to assess which fraction of these health outcomes that can be attributed to the risk factor. And so when we have this population attributable fraction, we multiply with the YLD and the YLL from the GBD study to obtain the DALYs for these health outcomes. So here are the first and initial results for this. This is for road traffic noise, and it's for the total countries to the left and for the capital cities to the right. This is for road traffic noise only. And as you can see, the dark blue represent the YLD from high annoyance, and the lighter blue, the YLD from high sleep disturbances. And at the top, there is a light blue, which is both YLD and YLL from ischemic heart disease. And we presented the results as rates for comparison between the countries as well as between the capital cities. And yes, as you can see, the pattern for the capital cities is also reflected in the pattern for the countries. And as said, these estimates are based on the data that are reported to the European Commission and from the strategic noise mapping. But when we dig a little bit more into this, we found that this data was not comparable. So we need to scrutinize the data a bit more. And when we looked at this, we found that the criteria used to define the geographical areas of the agglomeration, they were different. For example, Sweden, they appear to strictly include municipalities with more than 100,000 inhabitants, that is strictly adhering to the ENT criteria. Whereas Finland included municipalities with more than 100,000 inhabitants, except Kauniainen with 8,500 inhabitants. But Kauniainen is in the middle of Helsinki, so that is perhaps not at rare. But for Norway and Denmark, they used more flexible definitions and included also adjacent agglomerations when these aggregated to a more continuous urban agglomeration. For example, Oslo and adjacent agglomerations. And this can also be seen in this map, where you can see the different capital cities. And the thick line is defining the border of the municipality. For Norway, the pluses are those areas also included in the definition of the agglomeration in the different countries. And as you can see, both Copenhagen and Oslo included more areas around the municipality, even though, for example, Norway have lesser population density, for example, as Helsinki, which did not include these areas in their reporting. So that was one different things that makes the data not comparable. And so we quantify this impact, and we looked for Oslo, for example. Of course, the total DALYs were higher when we looked at the city plus the adjacent agglomeration. But when we looked at the rates, there was a reduced rate when included adjacent agglomerations. And you can see that for both Oslo, Helsinki, as well as Copenhagen. For Stockholm, we couldn't compare this because they didn't include, we had only data for the Stockholm municipality. And this also was observed for railway noise. And for Copenhagen, we had no data from the end reporting. So, and another difference that we observed between the Nordic countries was in the noise assignment method. Norway, Sweden, and Denmark, they use the Nordic prediction models and assign all inhabitants in a building to the highest noise level calculated for the most exposed facade, as you can see in the simplified picture here. Whereas Finland employed the equal distribution principle according to the Knossos EU method, as you can see here. They equally distributed people in the building so that fewer people actually will be assigned to the most exposed facade. So for Helsinki, they reported this equal distribution based data to the European Commission, but they had also assessed noise in the old way, like the most exposed facade. So we could actually quantify the impact of these two methods. And for road traffic noise, the equal distribution based data resulted in 56% lower DALY estimate compared to the most exposed facade assignment. And for railway noise, it was even a bigger difference. Yeah. So I also wanted to show you some results where we compared the end-based results with the results when we use these nationwide noise models. And as I said, the nationwide noise models were only available for Norway and Denmark. And this picture showed the results for Norway and Oslo. And as you can see, when using the nationwide noise model, the DALY rates increased with 51% compared to the estimates based on strategic noise mapping. And for Denmark, it was even higher difference between the Danish nationwide model compared to the end-based model. And if the models were similar, you should expect quite similar results for a similar geographical area. But for example, for Oslo, the end-based data showed higher rates. So it's obvious that there's also other differences between these models, but coverage seems to be also have a big effect. So yeah, these are the final results that are our main results. And here we have estimated the DALYs for the Nordic capital cities using the most comparable input data. That is using strictly the municipality data and noise exposure using the most exposed facade assignment. And here you can see that the data, the estimates are more similar than the previous one. And here we have also included the additional outcomes, stroke and diabetes on the top here, in addition to high annoyance, high sleep disturbances, and ischemic heart disease. And yeah, it's increasing with this additional health outcomes included. It increases the DALY estimates about 15 to 17% or so. And for railway noise, of course, we have included only annoyance and sleep disturbances. So this no comparable data based on N could be reported for the entire country. And so to sum up, estimated DALYs based on the N data reported to the European Commission, they are not comparable. And this is due to differences in the definitions of the geographical areas, that is the areas included in the urban agglomerations. And there were also differences in the noise exposure assignment method. So we could only report comparable estimates for the capital cities, and they show that between 300 and 500 DALYs per 100,000 for road traffic noise, and a little bit lower rates for railway noise, between 40 and 140 DALYs per 100,000. And the BOD assessment based on the end clearly underestimate national burden due to transportation noise. And so further harmonization of noise exposure modeling is very important to assure comparable BOD estimates across countries and cities. So that was the end of my talk, and these results were published last year. So if you're interested, you can look up this paper. And thank you so much for listening to this presentation. Thanks.
Yes, thank you very much, Gunn-Marit, for this very nice presentation of your impressive results. For the discussion, we have planned that I will hand over to Juanita Haxma. Juanita, are you there? Yes, perfect. So I will hand over for the moderation of the discussion.
Thanks, Dietrich, and thanks to Eulalia and Gunn-Marit for the very nice presentations. Are there any questions from the audience for Eulalia or Gunn-Marit? Yes, go ahead, Matthias.
Yeah, thank you for the nice talks. And Juliana, I would have a question concerning. Sorry, so there's some noise. As far as I know, the new methods, your END methods, will have higher number of exposed for airplane noise. In Frankfurt, it's about a factor of 2. Maybe that's special for Germany. But then the second step, the same problem as Gunn-Marit mentioned. Now we have different rules to count the exposed. As far as I know, now it's only half of the noisiest facade points, as before it was all facade points. Will you deal with that in the new report? Or rather, how will you deal with it?
Yeah, so the changes for this, I mean, I spoke about the changes about the health risk assessment and what we will do with the health risk assessment. I think what you're asking is like about the the calculation methods of the noise. There are changes on this, and obviously this also will have an effect of the results. So before, in 2017 and 2012 and etc., countries were able to use national methods or interim methods. So this resulted a bit like, you know, Gumarin said, different countries using different things that were not so comparable. From now on in 2022 and in the future rounds of noise mapping, all countries, they need to use NOSOS. So they will have to use NOSOS, and also there is a change on this, how you assign people into the facade, and Gunmarit has represented this very well, because before some people were using the most exposed facade, so all the people were going into the most exposed facade, but now the methods have changed, so they have to use more this equal distribution method, which assigns like people, not everybody into the most exposed facade, but there is a kind of a distribution around the building. So we will, I think this also will have an impact on the number of people exposed, and consequently into the number of people suffering different health outcomes and into the burden of disease. I don't know yet how this will affect, so, but we will, yeah, try to explain this or try to address this in the report as well. So thanks for the question.
Thank you. Any other question? Did this answer your question, Matthias?
Well, yeah, I would have hoped to have an answer, but now I know they will address, but Eulalia cannot tell yet how, but it's okay.
Okay.
I have not seen the numbers yet. I think for some countries, the numbers go down. It depends also on the, for what I understood, how the buildings are. If it's like a block of flats, like a country that has lots of blocks of flats, or unifamiliar houses. So it really will depend on the country and how their national method compares to NOSOS or what they're doing. So there is, we have some reportings, of course, but not for the whole countries. So I cannot say yet how this will affect. I think in the majority of the countries, there will be a little decrease in the number of people exposed to noise, but in some other countries, like for example Germany, there is an increase because of this comparison, yes, of the national method and the new method.
Okay,
thank you so much. Dietrich, go ahead.
Yes, I have a question for Gunmarit. So I've seen the differences in railway-related burden of disease are quite strong between the countries. Is there a reason? Is that simply related to the size of the railway network, or how can you explain these bigger differences?
Yes, I think it's because of the higher exposure to railway noise. I think they're reflecting exposure, that this is differ much more than road traffic noise, because road traffic is everywhere, but railway noise, at least in Oslo, we have more trams and metro above ground than in the other Nordic countries. So I think it reflects that, but of course it may also be differences in exposure assessment that is not possible for us to know or dig more into. But there's so many differences in exposure assessment that could be also be resulting in this. Of course, that is difficult for us to know. Yeah.
Okay, great. Thank you very much.
Yeah. Brecht, go ahead.
Thanks to both of you. I have a question for Gunn-Marit as well. So you and many others who are doing these studies see that the largest share of the burden is linked to the annoyance and the sleep disturbance, but always struggle a bit to see these outcomes at the same level as individual diseases like ischemic heart disease. So I wonder if you have any thoughts, any insights on the extent to which we can conceptually combine these two in the overall burden of disease framework. Thank you.
Yes, a good question. As I told you, this health loss due to annoyance and sleep disturbances, they are assessed directly based on the exposure response functions and the exposure, and it only includes those highly annoyed and those highly sleep disturbed, and WHO also look upon these health outcomes as health loss that needs to be prevented. So I don't think that I have worked so many years with noise, so perhaps I look upon these as health effects. Of course, not that serious or as ischemic heart disease, but they are more widespread. It's more common to be high annoyed, and that is why these outcomes contribute to the big share of the total burden. And even though and that's a nice thing with this DALY estimation, I think that even though these health outcomes are more adverse than annoyance and sleep disturbances, they don't, you can see from the DALY contribution that they're not that big as the other health outcomes. So I still think it's important to prevent high annoyance and high degree of sleep disturbances, because they also could be on the pathway to more adverse health effects. So yeah.
Thank you.
Was that a question? Answer?
Those are indeed good insights.
Yeah.
Thank you. Miriam, go ahead.
Yeah, thanks a lot for the super interesting presentations. I think it's amazing to see how the science evolved there, because when I did my first risk assessment for that, I also was exactly looking at the same endpoints which Brecht was saying, like annoyance and sleep disturbance. And now we have diabetes, we have all-cause mortality. I think this is amazing how we develop, or how more science is coming up. I'm wondering, how is it with other pollutants, such as air pollution? Do you also see an increase in evidence looking at both together? And are you also considering to do this in the future?
Was that a question to me, or?
Both. Okay. Sorry, to both of you.
Okay, perhaps I can start. Yes, of course, these are related exposures, air pollution and noise. And in the project Best Cost, we include both air pollution and noise. And we try to harmonize the burden of disease assessment from these two exposures. And of course, I think it's important to use high quality exposure response functions. For example, for noise, those both noise and air pollution increase the risk of cardiovascular disease. So it's important that we adjust for air pollution, for example, in noise exposure studies, and that we have good exposure characterization in studies, and that we don't and vice versa for air pollution, that they also adjust for noise in their studies. So I think that that is one way to not double count the DALYs based on these exposures. And but I'm a little bit hesitant to include this all-cause mortality for noise and for air pollution as well, because I think it should be cost-specific. And for example, if we adhere to the Global Burden of Disease project, they don't include all-cause mortality. They look at disease-specific or cause-specific, both, of course, in morbidity as well as as well as mortality. So I think I'm not sure I'm in favor of including all-cause mortality. Yeah.
Okay, so on the air pollution and noise, for example, in the agency, we had two different evolutions, let's say. For example, for noise, we were basing all our health risk assessments on morbidity. So from the very beginning, we started to, okay, annoyance, sleep disturbance, maybe also some cardiovascular outcomes, etc. Whilst the colleagues of the air quality, they were basing their health risk assessments on mortality, because of course, the numbers of mortality for air pollution are so much higher. I think, you know, one interesting thing from the epidemiologists that work with us on the European Topic Center was that it was showing some results. So and he was saying that in air pollution research, is much less frequent to account for noise than, for example, in noise research, we many times account for air pollution. But the funny thing is that in air pollution, when they adjust for noise, the estimates, the relative risk, etc., they become much smaller. But like, for example, for noise, when we adjust for air pollution, the estimates are a little bit smaller, but not so much. So this is what, I'm not an epidemiologist, this is what he was saying, and I thought, you know, it was interesting to bring this. Just one thing about the all-cause mortality. This was selected again because some new studies, they show that noise, it's not only causes like, okay, some specific mortality, but there have been studies showing that it's linked to all-cause mortality. And there was a meta-analysis about this. And yeah, as I said, this will be published and will be explained why. But yeah, this is the explanation for now.
Perfect, thank you. I see Elisa has a question.
Yeah, thank you. Thank you both for the nice and very interesting presentations. I'm afraid we have to have a little bit patience on this new health impact assessment report, so I'm waiting for it. But I noticed that in the study of Gunmaret, they used source-specific exposure response relations for the cardiometabolic endpoint stroke, this chemical, and I was wondering, did you also consider to use to apply, for example, an exposure response relation for road traffic to assess the health impacts for rail traffic? Because I don't think that a heart attack that is caused by road traffic noise differs so much from a heart attack that is caused by rail traffic noise. And also, yeah, because there is not an exposure response relationship available for rail traffic noise, it does not mean that rail traffic noise has no effect on the cardiometabolic system. It's just the studies are not there. That's the only thing. So I would wondering, what do you think of that? Should that be possible? Or to, yeah.
Yeah, I totally agree with you. And in such, I think that we perhaps choose a little bit conservative approach, including only those with quite consistent evidence base. And as you said, it's not so many studies looking at cardiovascular risk and for railway noise and stroke and diabetes, but it's Nordic studies published from the Norwegian also found increased risk for railway noise, actually, in the same number of size as for road traffic noise. So we could also have included railway noise and ISD, I think. And but I still think it's needed with a scientific strong scientific base. and not just think that since it's a noise source, it has the same effect. But
yeah,
I think we
yeah,
need
but maybe the meta-analysis that are included in Eulalia's new upcoming report could also include some exposure response relationships that are not source specific, but that are the results of meta-analysis that investigate all the three sources, and then you can make a combination, because then you have more studies and you have a more robust estimate.
Yeah,
that would be my. So I would, maybe that's something for you to include, Eulalia.
Yeah, I just to yeah, I totally agree that it should be perhaps more flexible. Working with noise in so many years, it's very you think very source specific actually, because the exposure assessment, it's very source specific, and but of course it's a combination as well. And if you're exposed to more sources, you're also more under risk, I guess, also. So
yeah,
definitely needs.
And I have another question. It's about the prevalence DALYs and incidence DALYs. Now you combined the DALYs of annoyance and sleep disturbance with the DALYs from cardiovascular disease, and annoyance and sleep disturbance are prevalences, in fact, and the others are incidences. Is it allowed? But maybe it's also a question for Juanita, because she's the DALY expert. How do you think about that? Is that possible, or? And now I stop with questioning.
I can answer that, because I have, I have a little bit strong feelings for this. I think it's, I see that some people report have used prevalence risk estimates because they estimate prevalence DALYs. But I think I think it's important that we include the risk estimates based on longitudinal or cohort studies that estimate the incidence disease, and the risk estimates based on that, and not from prevalence, that is the cross-sectional studies. So that is just the strength of the scientific basis that you use for health impact assessment. But you use the background prevalence because you estimate the DALYs for a year. So then you,
that's not how we do it.
It's a little bit of a misunderstanding, I think.
Okay, that's not how we do it, but maybe Danny can help me with that. But that's not. No, what I mean to say, the annoyance and also sleep disturbance are assessed in cross-sectional studies. So basically, you assess prevalences, and of course, ischemic heart disease is assessed best in cohort studies, so you should use that. But combining that in one metric in a DALY,
But still, the questions regarding noise, annoyance, and sleep disturbances is assumed to be long-term. How annoyed and how sleep disturbed are you during the last 12 months? So you're assuming a kind of long-term annoyance is not an acute effect. Or I think it makes sense. True. I think it makes sense. And the Global Burnout Disease Project, they always use prevalent background data, prevalent disease, when estimating the at least for
I was not aware of that, but okay.
Yeah, I think we've reached the end of the hour already. We're already past 12 o'clock. So I think we should end the questioning part now. I just very quickly want to mention that the noise disability weights have been accepted for publication in BMG Public Health. So they will be online somewhere soon, but I will keep you posted on that. Thank you. I'll give the word back to Dietrich for to close this webinar, I think.
Yes, I will not make long words. So thank you very much again for Eulalia and Gunn-Marit, and thank you for all the participants. I hope you have have heard some new insights, and we'll keep you posted if there will be some webinars or anything which is going on environment and environmental burden of disease and noise. So keep a look at our website. Bye-bye.
Thank
Bye-bye.
you.
Thank you.
Thank you very much.
Bye.
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 Bye. Bye.
Bye.